I started at the National Cancer Institute, where I ran the medical breast cancer program. Larry Norton was actually my first fellow, so that's kind of my major.
All you're telling us is how old you are.
Right. I actually am younger than Larry. And from there, I went to Georgetown University. I ran the Lombardi Cancer Center and the Nina Hyde Breast Cancer Research Center. And then about 8 years ago, I went to the University of Michigan, where I was chairman of medicine. And for the last 7 months, I've been here in Miami, where we are rapidly building a world-class breast cancer program. We have already recruited about 16 breast cancer clinicians and scientists. And I guarantee you that over the next year or two, you will see one of the most remarkable breast cancer programs in America in Miami, so that will be available to you. What's very interesting is that in each and every one of these aspects of my career, critical advocates, and invariably women, have been incredibly important in driving the breast cancer agenda. Rose Kushner, who many of you may have heard of at the National Cancer Institute, was one of the first people to say women don't need mastectomies and really to draw attention to this. Later at Georgetown, Nina Hyde, who was the fashion editor of the Post, a wonderful woman, through her tremendous dedication was able to help us with our work enormously. And now women like Evelyn and women like you make this all possible. The Breast Cancer Research Foundation, I should mention to you, because foundations can look alike if you don't really think about it. They specifically give all their dough to 150 people in the world. And if you asked 1,000 people who are breast cancer researchers to name the top 150, there'd be an awful lot of overlap with the people that are funded directly by this organization. And we come together and play with each other in ways that are meaningful and speed the process. So this is wonderful, and I congratulate you. In terms of what I am personally involved with currently in research, one more point I want to make, because people often don't see how things have changed. And when I started in breast cancer, half of the women diagnosed with the disease died of it in the United States. Half the women diagnosed died of it. Less than 1 in 5 now has a fatal outcome. Survival rates, cure rates, as you understand cure, 17–18%. That's not perfect, that's a long way to go, but that's a dramatic improvement. And most people don't appreciate how much progress has been made. And that is through your support. In terms of the things that I'm personally interested in, there are two very interesting notions about how we treat breast cancer that need refinement. We treat a lot of people who don't need it. A lot of women, when we had no treatment, didn't die of breast cancer, but we treat almost everybody now. So a lot of people are treated unnecessarily, and they don't like it, and I don't blame them, because there's side effects. And secondly, of course, our treatments still, by and large, tend to be somewhat cookbook, tend to be formulaic, tend to be less individualized than we would like them to be. If any of you had a urinary tract infection, we wouldn't just put you on an antibiotic. We would do a culture and sensitivity. We would know what the bug was, and we would eventually refine the antibiotic to match the infection. What we now appreciate is that breast cancer really isn't a single disease. It's a level of complexity that there's no getting around, but the notion breast cancer, prostate cancer is simply wrong. There are at least 5 kinds of breast cancer. Judy will tell you about one later in some of the questions, I'm sure. And each of these has a different approach and different pathways. So what we have been involved with is analyzing breast cancers and using results from studies involving hundreds of women who have already been treated, information that we can gather by computers, and try to design new ways of understanding which particular patterns, which particular genes that are expressed in their breast cancer tell us how to treat them. And for example,
so Mark, just tell everybody what gene expression means.
Okay. Each and every cell in your body has DNA. That's the library. That's the information base that each cell gets to know how it will behave. But what's amazing is that every cell in your body has the same library. Your brain cells, your liver cells, your breast cells all have the same library. But a breast cell doesn't look like a nerve cell, doesn't look like a muscle cell. So that each cell learns to only use some of the books in the library. And that ability to only look at some of the genes is due to which particular books are opened, and by opening a book in that library, you can think of which gene is expressed. So muscle cells express muscle genes, breast cells express breast genes. But it's even, unfortunately, a bit more complicated because, as I've said, there are multiple kinds of breast cancer. By studying these patterns, which we can now do enormously rapidly and completely, it's possible to devise discriminant tests. Perhaps some of you have heard of the oncotype test, a test where you can look at a few of the genes that are expressed in a breast cancer and make much more accurate predictions about who will recur and who will not. We are currently doing that to define exactly which women will have breast cancers that respond to individual drugs. Because right now, if you have been diagnosed with breast cancer and you get treated in the adjuvant setting to prevent your breast cancer from coming back, you only have a yes or no answer. Either you do great or perhaps you don't. But we have no way to assess have we made a good decision until there's some event that occurs later on. It would be so much better if we could look at the tumor and say, this is the right drug for you. And that's what we're working on.